What we're going to do tonight is just totally mellow, but we want to get you guys an experience tonight, just kind of start things off. I know where you are, in your second years, all of you. Yep. Awesome. Okay, and so we'll just go around just so I know what people's backgrounds are, and then we'll go from there. So I graduated in 2008. I'm from Kennebunkport. I still live 10 miles down the road, and I was a paramedic before school, and then went to uni, and then went to Albany, New York for residency in emergency medicine. Is that where you're from?
I'm from Lake George.
Oh, okay. So easy. Okay. So I went to Albany. I worked at Albany Med. It was a 1,000-bed hospital, and made it through, no problem. And ended up doing an allopathic residency, and we can talk about that offline at some point if people are interested in kind of hearing how I decided that. I decided to go out. I'm from Maine. Was going to come back here. Knew what I was going to do, but wanted to go somewhere else to train to get different exposure to different populations. And then stayed on as faculty for a couple of years there, and then came back and ran a flight program out there, and then came back to be with my friends back here. So I'm the medical director for the flight program out of Lewiston, and then I'm the director of the ER in Lewiston as well. And so it's great. It's great. It's fun. It's busy, but this is sort of, out of Lifeflight, and I'll let these guys talk further. Part of our, our sort of, what we do in addition to flying critical patients is we do a lot of outreach. And so I have Brad and Jackie who are part of the flight team and do outreach with the simulation.
So, yep, I'm Jackie Turcott. I'm one of the flight nurses at the Lewiston base and now the education coordinator for the whole program.
Congratulations.
Thank you. Prior to I've been there 8 years, but 15 years of critical care experience prior to that. So, and that's what brought me to Lifeflight. So I've known Dr. Tilney for a long time when he was a paramedic. So, and like you said, we do HPS training throughout the whole state for varying levels of, from physicians, EMS, nursing, all throughout. So this will be good.
I'm Sam. I'm second year also. I guess we all are. Before going to medical school, I was a paramedic as well.
Great.
Worked out in Western Massachusetts for Bay State Medical Center.
Great.
And I kind of miss being off the ambulance, but I enjoyed the challenges of medical school.
Great.
Still work as a firefighter in Saco, which is kind of fun.
Great.
Parth. I graduated from Rutgers University in 2013, and then between then and coming here last year, I worked as an ER scribe. And that's basically my clinical experience.
Awesome.
And basically I've been living in Jersey my whole life until moving here.
Right on.
My name's Bruce Grattan. I graduated in 2007 and have been doing some other things in the meantime. Did some research, worked as a dietitian, still teach nutrition, and did some EMS work in between, and here I am.
Awesome.
Kelsey Bean. I did a bachelor's at UMaine Machias and then post-bac in Orono. Paramedic in Maine, started up in the Bangor, Machias area, and now I've been at Lisbon for 4 years.
Great.
I'm Sat. I had zero background in any emergency medicine at all, clinically or otherwise. Biomedical engineering is my background.
Nice.
I'm Liz. I graduated from UNE in 2009, and I have research experience, but no clinical experience.
Nice. No, you got
I'm Austin Bass. I graduated Clark University in 2010, and I was an EMT there. And at the same time, I was a health officer at Camp Hines in Raymond.
I know Camp Hines. I went across the lake at the other camp across the lake when I was Kingsley Pines. Yes.
Yes.
I would have meant that. Okay.
Classic.
Right.
Anyway, yeah. So I went and did a post-bac at UVM and did some ER research there, and then got in here. So. Yeah.
I'm Alicia. I went to Tufts for undergrad. I have no emergency medicine experience.
Awesome. Awesome. Oh, John.
I'm John Cooper, and I'm a career changer. I did 28 years in network news as a freelancer around the world, and I'm doing this.
And my name is Brad Boringer. I also work for Lifeflight, obviously. I am, just like Jackie, a new role for me. I'm the actual base manager for our Lewiston base as of a few months ago. So big role shift, but I come from an EMS background that transitioned to nursing, did ER nursing in New Hampshire, still do in Boston, and then have transitioned full-time to Lifeflight as a critical care nurse and medic. But I've done a bunch of simulation in the past, and actually just got back from Finland after being there on a Fulbright doing nursing education simulations work at one of the universities just near the capital in Finland. So all of us sort of have a passion for experiential and hands-on education, which is why we run around with this guy to various hospitals and programs. So that's kind of what brings us all here tonight. So yeah.
Yeah, there's a nice guy in the back.
Rick, 1-year ground medic, 6 years ops manager in Lewiston, 7-year flight medic, and now they've given me my own division to manage. I have 4 employees. That's one of them on the stretcher there. And they're plastic. You know, the manager. So I go all around the state with a training program, and I also help take care of weather monitoring systems down the state, infrastructure.
Nice, thanks. So what we're going to do here, I mean, so, everybody, thinks about this emergency medicine, we said this, emergency medicine is the backbone of sort of, of medicine, because, like if you're working as a family physician or it doesn't matter, a neurosurgeon, or whatever, a nephrologist, you're still going to assess your patient the same way. You're still, and, you start as a generalist and you're still, going to look at the patient, and I'll use the, folks' little EMS experience just to, kind of give us our sort of template of how you approach this. And the reason simulation is awesome is because, again, it's an emergency medicine model because in emergency medicine, I'm a guy with ADD. I got to have everything answers within 15 minutes, or I get bored and I want to move on to other things. And so, it's, if you're a family physician or a nephrologist, you see a patient, you do this nice assessment, you take a nice HPI over 30 minutes, and then you send your labs, and you have a couple days of labs, and then then you get your labs back, and you're like, whoa, that creatinine's 5, or, whatever it is, you do over the course of things, of course, over weeks. Versus the reason we use the emergency medicine model is because we have, 3 minutes, and when I have, medical students or, residents working with me, I play the 6-second or 6-minute rule. If you walk into a room and because, again, I'm not interested in, saying, okay, see one, do one, teach one. If you've been in the room with me once, that's enough. Good luck. And it really is, because you already have gone through your CSA, or you will have by the end of this year, and you will learn the art of taking histories. So when you walk into a room, if you see somebody who's sick, you have 6 seconds to turn around and come out. Or you have 6 minutes to do your assessment and decide what your treatment plan is and move on and come out. So I love this model. So we'll do, and it doesn't matter that you, again, have no experience or you're working as a paramedic, because you're just going to build upon that. And again, by internship year, you're all going to be the same, and you've all, your various levels, and you're going to figure it out and move on from there. So the thing about, the reason why, simulation is so useful is, and the cases that Jackie and Brad and I have pulled are all cases that came out of flights. And so, these were actual people that we had along the way. And so the idea here is, yes, you want to make the mistakes on the plastic guy, not the real person, and that's why it's awesome. So what we'll actually do is we'll have the same scenarios, one in each room, and we'll flip-flop. And so we'll do, and about the thing about it is, this is an opportunity to put do stuff that you've never done before, so that you can say, oh yeah, I put in a nasal airway in. Oh yeah, I put an IV in. Oh yeah, even if you haven't done it, you'd rather do that first rather than what the 4 of us did was, when there was no fidelity, be like, hi Mrs. Smith, I never started an IV on anything before except for to be honest, when I went through at CMMC, did my first IV ever. It was like, oh God, here I am, 19 years old. This is awesome. This is the coolest day ever. And so you'd rather just do it here, and realize, and oh, okay, and figure it out. And so then the thing is also, you can do scenarios, you can do the same scenario 20 times, and so, and that's why it's so useful. So, and when we did the exact same thing when when I went through here, we had an older mannequin. We were in, the OMM room, backside of the OMM room, doing scenarios at lunchtime, and that's what we did. And so this is where you guys are going to, take it. And yeah, you've got people here with some experience. You can do it all yourselves and show each other by the end, and so, and and know how to use a laryngoscope blade. So by the time you get to ACLS, you guys doing ACLS at the end of second year? Is that right? March. Okay, so by the time you get there and then colloquium and all that stuff that you guys do, you're well on your way already. And this is an experience, again, that will give you just a little bit of sight so that when somebody like me says, hey, listen, come on, we're going to go do, or these guys say, come on, let's go do this. You're already cued in a little bit. You already know the laryngoscope goes in your left hand, not your right. And that's key. So that's sort of the background for simulation and why it's useful, and it is really useful. And so being able to use real life fidelity is it helps you and as a provider getting more and more experience. So what I would like to do is I would like to use a couple people who just and it sounds like various levels of previous experience, but I'd like to have to demonstrate just an assessment of someone who's awake alert and talking to you, and just so that we're all on the same page. And then I'd also like to just do a patient who is essentially unconscious and just do an ABC assessment just to make sure we're all speaking the same language when we do this. And then what we'll do after that is we're not going to talk anymore. We're going to go do stuff. So does that sound like a reasonable plan for the evening? And then we'll do a culmination at the end of the evening is 2 scenarios, and then just open it up and see how people do in the last scenario. Okay. Who wants to demonstrate an awake alert person who's just sitting here hanging out, do an assessment on Brad, please?
I'm happy to.
Go.
Hi, Brad. My name is Sam.
Hey, Sam.
Second year medical student. Awesome. I see your skin is pink, warm, and dry, and you're not sweaty.
Is your attending here?
He's actually not. But you're definitely moving around, and you're oriented to time and place and funny jokes, which is looking good. I don't see any obvious deformities anywhere. What brings you in today?
I was working on my house, putting a new garage on, and I fell about 5 feet off some scaffolding and landed right on my ankle, and I just sort of rolled it over.
Okay.
Yeah.
So when you fell at 5 feet, did you just land on your ankle? Did you hit your head or anything?
Nope, I just totally landed on my ankle.
So you remember everything that happened?
Yeah.
Okay, I'm not going to touch that anymore then. How'd you get in here today? Did you move the wheels?
Took an Uber.
Took an Uber. We have Ubers in Maine?
Yeah.
Is it like a tractor or John Deere Uber?
Yeah. You pick. It's like Uber X, Uber tractor.
Okay, so on my initial assessment, I'm not worried about anything critical. You're here, you're conscious, you're alert, you're talking.
Okay, so yep. So you've already done. So you've done your neuro exam. Mm-hmm. So go back even further back. What did you notice about And I'm going to go back to everybody taking CPR at some point. Mm-hmm. Okay, so go back to. We're going to bring it back even that far. Yep. So what have you noticed in your your CPR assessment? Think about it.
He's breathing.
He's okay before that.
He's conscious.
Yep.
His skin looks good. He's not pale.
Does he have an airway?
Yes, he's talking to me.
So airway, yes.
Yep.
He's breathing. You've already said that.
Yep.
What have you noticed about his breathing? His breathing when you look.
Is appropriate. He's not tripoding. He's not using accessory muscles like the sternocleidomastoid. He's not nasal flaring. He doesn't have pursed lips.
Great. So airway, breathing.
And then circulation. I touched his skin. He was warm and cool and dry, and he, nice and pink.
Perfect.
Good peripheral perfusion.
Great.
So my 6 seconds, I'm cool with the 6 minutes.
Perfect. So airway, breathing, circulation. D I use for disability. That's your neurostats, which you already did. Totally fine. And then if you did it exactly right. E is exposed. So that's your primary assessment. That's it. And then then we get all the the sort of the parts of it, past medical history, all their, but we're thinking about your critical systems: airway, breathing, circulation, and disability. Great. All right. That, no trick questions here. We're just kind of making sure. And then what's going to, and the way this is, you're going to end up doing this is then you're just going to wrap in, all this stuff that we're doing, with medical school. You're going to be thinking, when we have a patient who's having, traumatic injury or a stroke or whatever, then you can be like layering in, Frank Willard and, all these people that are coming, through. Frank Willard I still dream about Frank Willard and have nightmares. Yeah, absolutely. Can we pop him lower? No, it's good. All right. So who wants to do the unconscious? And it's this easy.
Where's our other paramedic?
Does anyone else want to practice?
Doesn't matter. There's just a demonstration because what's nice is I'll have you guys do the demonstration, and then have other people step up because again it's nice.
Where am I?
You're in this room. This is unconscious person.
I just walked into the room?
Yep.
Sure. Sir? Sir? Are you okay?
Nothing.
Could you go activate 911 for me, please? Thanks.
All right.
I have a carotid pulse.
Yes.
We're breathing. I don't hear any snoring, so I'm thinking that my airway is probably open. We're getting good respirations with good chest rise. No indications that the airway is clogged. So,
say you weren't getting that. How would you open the airway?
at this time where they're unconscious, I'd probably do a jaw thrust. Come
Perfect.
up underneath. That way I'm stabilizing C-spine because I don't know if some traumatic event happened
Perfect.
when they're unconscious.
Perfect. Okay.
I'm gonna, I probably need extra hands at this point, and then we'll call it
Great.
911.
So, I mean, again, totally straightforward. This is, you guys have been through this already. So, then you layer on, okay, why is this person unconscious? Who cares? And that's what we're going to do here in a few minutes. But the same thing, you walk over to the patient, Johnny, you okay? Does he have an airway? A, B, C, D again, D, disability, why is he unconscious? Do you need to think about trauma? And this is not, and then exposing what you need to expose. So and then we'll layer on some of this medicine. So, but the approach is exactly the same. When I walk into a room, the only thing that I do differently from you is I come in the room and I sit next to the patient. And I really do, on every single patient I ever see in the ER, I come in and sit next to him. Hi, I'm Pete, and sometimes it's hi, I'm Pete, and sometimes, hi, it's Dr. Tilney, like depending on what you have. But I always, I'd say, I approach them and I say, hey, how's it going? What's going on tonight? And and it's 100%, you just do this over and over and over. And I grab on their pulse and say, and talk to them and say, and it's, this, you'll just do this thousands of times. And so the same thing with your unconscious patient. It doesn't matter if it's a trauma or, or a medical patient. So. All right, so we've done this. Oh, there we go. Nice, Brad. All right, so now we're all on the same wavelength. We were all probably on the same wavelength before, but I just want to make sure we do that. So what we're going to end up doing here is layering pieces. So we'll have a couple different scenarios here. And there's no right answer. You bring on your pieces. We've heard from these nice folks who kind of gave us a background. And so when we go and do these scenarios, you guys are going to be in charge. And I'd like to hear other voices, when we do this. Questions, thoughts, ideas? Yeah.
What exactly is the difference between airway and breathing?
Great question.
Have an airway.
Yeah, so it depends, so she's, tell me your name again, sorry. Kelsey came in and said, hey, this person's breathing. You can have people who are occluded. Snoring is an occluded airway, right? So you're deciding, is there puke in the airway? Is there some foreign body in the airway, chicken bone, so you're trying to determine, if they're doing this, then they don't have an airway. So and sometimes when you're taking care of a patient, you guys are doing pharmacology, right? Or simultaneously right now? Simultaneously. So have you guys done antihypertensives recently? Not yet? So
A little bit.
a little bit, okay. So did you guys do lisinopril? Yes. So we had a lisinopril, the other overdose, not an overdose, but an allergic reaction the other day. So this guy came in and he had his airway is completely occluded. And so the doctor never got beyond A. In the first 20 minutes of taking care of this patient, never got beyond A. And it didn't matter what his past medical history, it didn't matter what his prolonged sounds were, A until he got an airway. So, and he did, and so that's why, so then you can say, oh, okay, after you get the airway, then you can think about breathing and then, your circulation after that, so.
So you could have someone who has a patent airway, but they're not breathing because they had a heart attack. So their airway is fine, still not breathing.
Perfect. Yeah, totally. Add it later in. So, but great question. And then, in that, and then, the circulation piece of it, there we go. Pulse, skin, blood pressure, are they bleeding to death? You walk up to somebody, again, I had somebody the other day who almost amputated their leg and was, hey, how's it going? I'm feeling terrible because my leg is bleeding, and we said, great, airway breathing, done. I'll go take care of this person who's exsanguinating out their, lower extremity. Okay, on Coumadin with an INR 5, okay. So, so that's the kind of thing that you just assess quickly and you're like, okay. So anyways, all right, so any other questions? Great questions. We're not even getting to your secondary assessments. I don't, these are all primary, everything that we're going to talk about today are primary assessment problems, and kind of go from there.
So I think one more thing to add is
Yeah.
this is a fault-free environment. Like, don't be embarrassed about making mistakes or doing something wrong. I think, you know, generally, like, what happens in this room will stay in this room, except for the video camera that John has. But, you know,
YouTube, right?
is that they're going to push all of us until they find things that we can improve upon. So don't be embarrassed that you haven't done one of these before.
That's what it's about. So, I mean, we're going to talk about, you know, if you have to put an IV in somebody and you haven't put an IV in, we're going to do timeout. We're going to talk about IVs, you know, and if you haven't put an airway in, we're going to time out and do that. You know, there's no rush here. You know, we'll get through it and then we'll debrief at the end. So, perfect. Okay.
Hi guys, I'm Jackie with Lifeflight. I've got Hal here. He's a 60-year-old gentleman involved in a motor vehicle. He was a driver. He was T-boned on the driver's side. Long extrication. He's complaining of left-sided chest pain. When we picked him up, he had a left thigh deformity. He was a low speed, 20 miles an hour. The only thing we'd given him was 50 of fentanyl and placed 1 IV in. 50 mics of fentanyl for pain.
What's his name, sorry?
Hal.
Hal, I'm just going to take a quick peek at your legs here.
Is Hal speaking?
Lungs seem to be
He
clear.
has bilateral pedal pulses.
Is fentanyl was given?
Yeah.
Oh, that's right.
What did you take?
When I asked him, he said he didn't take insulin. He just said that he took oral meds for.
No heartbeat?
I was able to hear lung sounds for a little bit, but I don't hear a heartbeat.
What's his name? Sir, can you hear me? Okay.
No heartbeat?
He's talking.
I'm sorry, guys. I've got a heart rate of 110, blood pressure 114/85, and I got SATs of 90%.
Okay. Our trauma assessment, we had what was wrong with him in terms of injuries?
Yeah, it's definitely strong pulses all the time.
Sounds like he has diminished lung sounds on the left. I just want to take a listen and see if you confirm.
He said he has chest pain. Did you find any bleeding or anything like that?
When I felt it, I didn't feel air. I felt like that bony crepitus on that left side. You know,
Okay, so possibly a broken rib?
Yeah, I'm not quite sure. That's what I thought I felt when we were assessing him initially.
And you said there were decreased breath sounds
It sounds like the decreased breath sounds on the left.
on the left. Is that where your preference was?
That's where it was, right on the left-hand side,
So
yeah.
you could be dealing with pneumothorax?
Absolutely.
Okay.
I do.
Go for it. So Hal, we're going to put a little needle in your chest right over here. It's going to help you breathe a little bit. You're going to feel a little bit of pressure. Just hold still for it. A little bit of pressure there. Not so bad.
Can you have a sharp
Take it out, take it out.
There's no.
Did we hear any air? Fantastic. Okay.
I'd like to get a seal around this so you can, or we can,
Like
a flap
tape
out.
or something?
Yeah, you do something to secure it.
Okay.
So
is he breathing better?
better, but my chest is still really hurting me. You know, my breathing's a lot better, but you know, it's hurting me on that left side.
Can we get an AP chest film?
Oh.
They're in the other trauma bay. There'll be a few minutes.
Okay.
Do an ultrasound?
Yeah, do we have it fast?
Yeah.
It's in the other trauma bay.
Okay.
Good thinking, though.
There's 2 people involved.
There's 2 people involved. I'm sorry, so the story was there any loss of consciousness before impact?
They told me that when EMS arrived,
So
because I
we're
just
gonna
picked them up
assume
from
there's
EMS, I need about 2
security
minutes of LOC.
Okay.
Okay. But no story about what happened before the impact?
No, when I talked to him, he
Normal. Cool, so we should also get creatinine and all sorts of stuff like that. I don't want to give him aspirin, though.
Why not? No aspirin, why
He has a
not?
pneumothorax, he could have bleeding.
Oh, okay.
Yeah, I'm not exactly sure. I'm not convinced it would be bad, but I just don't know enough about it.
45 seconds.
So let's get him to the.
I did take his splint off, I would tell you, because we can't fit the traction splint. Initially, EMS had put a traction splint on him too,
Forgot about the
by
leg.
way.
I had to take it off because it just doesn't fit in the aircraft.
Pedal pulses are good.
Doctor, my chest hurts.
Do you have any
My leg hurts. What are
deformities?
you going to do about that?
Do you have any deformities on the leg?
Oh, what are you doing to my leg?
Okay.
I'm sorry, Hal. We just have to check and see what's going on.
Yeah, but can I, so I could use some pain medicine there, doctors.
Yeah, let's give you
Oh.
75 fentanyl.
Yeah.
150 fentanyl.
Is that federal good stuff? It better be the
Stabilize his
strongest out there. I heard that the stuff called Tilney.
Comes with
Stabilize his extremity.
Would you like me to go ahead and give you? How much fentanyl would you like?
Good job. Good job.